Hello, everyone. Our topic today is total pain. These are the objectives of my presentation. You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die. Cicely Saunders. Total pain is a term that was coined by Dr. Cicely Saunders, and it suggested that the pain can be understood as having physical, psychological, social, emotional, and spiritual components. The combination of these elements is believed to result in a total pain experience that is individualized and specific to each patient's particular situation. Total pain is both physical and non-physical. The non-physical includes spiritual, emotional, and social. The physical is usually is basically the nociceptive, the neuropathic, and the inflammatory components of pain that we see on daily practice. This nice table would show the difference between physical and non-physical pain. With physical pain, we're describing nociceptive, visceral, neuropathic pain from known tissue injury, psychological, such as anxiety, hopelessness, helplessness from medical uncertainty, social, fear of dependency on family, loss of role as a provider to family. Spiritual is despair from inner realization that life is finite and without meaning. We're going to jump into other types of mental disorders that we see both in pain and palliative setting. First of all, somatic symptom disorder. Second is illness anxiety disorder, conversion disorder, psychological factors affecting other medical conditions, factitious disorder, other specified somatic symptom and related disorder, and lastly, unspecified somatic symptom and related disorder. And all of these are according to the DSM-5, which will be our reference for today. I just wanted to give you a nice comparison between DSM-4 and DSM-5 because you're still going to hear many physicians um, using the DSM-4 terminology. So you need to be aware of it. Somatic symptom disorder used to be called somatization disorder in previous DSM. Illness anxiety disorder is basically hypochondriasis. Conversion disorder, nowadays we call it functional neurological symptom disorder. It used to be a conversion disorder. Uh, Psychological factors affecting other medical conditions, this one was not changed. Body dysmorphic disorder is the same. Um, Factitious disorder is the same. Other specified, unspecified somatic symptom and related disorder used to be called somatoform disorders, not otherwise specified. Um, Another thing is I wanted to talk about is body dysmorphic disorder. This was moved to obsessive compulsive and related disorders in the DSM-5. Take note of that. Okay, this slide is so important because it will give you the three psychological conditions that can cause pain. Okay, and this is our specialty. You need to know these three conditions. First of them is somatic symptom disorder with predominant pain. B, psychological factors that affect other medical conditions. C is adjustment disorder. So these are the three psychological conditions that are related to pain in the DSM-5. Somatic symptom disorder. It's one or more somatic symptoms that are distressing or result in signified disruption of daily life. Excessive thoughts, feelings, behaviors related to somatic symptoms or associated uh, health concerns as manifested by at least one of the following: disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms, excessive time and energy devoted to these symptoms or health concerns. Although one somatic symptom might not be continuously present, the state of being symptomatic is persistent, typically more than 6 months. In a nutshell, patient with somatic symptom disorder is preoccupied 24/7 with his body symptoms. So if he's having a little bit of achy back, he will exaggerate this and it will be like, okay, I'm having a huge back issue problem, this and that. So, of course, it's very distressful. And it's very common, by the way. Somatic symptom disorder is very common. Okay, the rest of the DSM-5 criteria specify if with the predominant pain, whether it's persistent or not, mild, moderate, severe. And this is just like an example of a patient with somatic symptom disorder. My whole body aches day and night, more than 3 months. I'm very tired all the time. I wake up tired, stiff every day. I can't do more than one thing at a time. No concentration. My legs always feel like I just walked a mile. I can't remember where my things are. I can't remember anything these days. This is a kind of very vague symptoms, okay, that you see with the somatic symptom disorder. I got mnemonics for it. Some ethic. Okay, we'll jump into another condition. This one is not very common, but it might become common in a country like Egypt, for example. You see more of this conversion disorder. Uh, I I do believe this is has to do with cultural, differences between the West and the Middle East and all that. I just this is just my own theory. But anyway, conversion disorder. This one was used to be called hysteria when Freud was researching. Uh, so I mean, in very old text, you will read hysteria. Hysteria means conversion disorder. Patient will lose control of bodily functions such as becoming blind, deaf, or paralyzed. And this happens without any physical damage to affected organs or their neural connections. Anxiety will bring on these symptoms. Functional neurological symptom disorder, also known as conversion disorder. Um, One or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. The symptom or deficit is not better explained by other medical or mental disorder. The symptom or deficit causes clinical significant distress in social, occupational, or other important areas of functioning or warrants medical evaluation. Specify symptom type: weakness or paralysis, abnormal movement, swallowing symptom, speech symptom, attacks or seizures, anesthesia or sensory loss with special sensory symptoms such as visual, olfactory, or hearing disturbance with mixed symptoms, and so forth. I want to say that I had a case where a patient um, had a sacroiliac injection. And following the injection, the patient complained that his both legs are paralyzed, cannot move them. Anyway, of course, I knew there's something wrong because I was totally far away from the spinal cord, and immediately I thought about I might have some of the local reached the epidural space or intrathecal. Anyway, we did MRI, everything. I mean, next day he's the same. We got the neurology involved. He said, by examination, his reflexes are normal, and but he still complained that he cannot feel or cannot move his legs. Anyway, after all this, uh, you know, uh, investigations, we went and told him basically that he's actually we couldn't find anything that just explained his symptom. So when we told him so, he went up and he walked in his legs. I mean, as simple as such. So and during the time that he was actually paralyzed, his demeanor really was like he wasn't really bothered a lot about what happened to him. We call this phenomenon la belle indifference, okay, where the patient is not really, giving really a damn about what's going on with him. Anyway, so this is the condition that I've seen it, and recently I've seen a case, a young girl with headaches, pretty severe headaches, had conversion disorder. And I wasn't sure that headache would be one of the symptoms, but actually I looked it up and you can get headache as part of the conversion disorder as well. Okay. We'll finish up the criteria, specify if acute episode or persistent, specify is with psychological stressor or without psychological stressor. I want to just point out that, whatever the patient is doing, uh, it has a psychological meaning to the patient. Okay. So you have to really dig inside, and try to understand where is this patient coming from, why he's doing this. Okay. There's always a psychological significance to what he's doing. Okay. He might not know about it, or uh, he will tell you about it directly. But if you really, interview the patient really quite well, you might be able to pick it up. Okay. Psychological disorders affecting medical conditions, also known as, in old days, we used to call it psychosomatic disorder. So if you hear this terminology, you know what you're talking about. Psychological disorders affecting medical conditions are basically medical symptoms or condition is present, psychological or behavioral factors adversely affect the medical condition in one of the following ways. The factors have influenced the course of medical condition as shown by a close temporal association between the psychological factors and the development or exacerbation of or delayed recovery from the medical condition. The factors interfere with the treatment of the medical condition. For example, poor adherence. Factors contribute additional well-established health risks for the individual. Factors influence the underlying pathophysiology, precipitating or exacerbating symptoms or necessitating medical attention. C is psychological and behavioral factors, and criterion B are not better explained by other mental disorders. In a nutshell, psychological disorders affecting medical condition is patient having a behavioral problem that has a close temporal relation with his medical condition. Okay, this is in a nutshell. And it's one of the three causes of pain related to psychological factors. Number one was somatic symptom disorder. This is number two, psychological disorder affecting medical condition. You will always hear this terminology, psychosomatic. Okay, this is the old terminology, but you need to know it because people still use it up to now. Okay, specify current severity, mild, moderate, severe, or extreme. Another condition used to be called hypochondriasis. Nowadays, we call it illness anxiety disorder. Illness anxiety disorder is preoccupation or hypochondriasis with having or acquiring a serious illness. Like, for example, patient will be preoccupied that he's having cancer, for example. Somatic symptoms are not present. If present, are only mild in intensity. It's not like somatic symptom disorder, where the symptoms are, or somatic symptoms are highly exaggerated. If another medical condition is present or there is a high risk for developing a medical condition, example, strong family history is present, the preoccupation is clearly excessive or disproportionate. There's a high level of anxiety. That's why they call it illness anxiety disorder. And the individual is easily alarmed about personal health status. The individual perform excessive health-related behaviors, example, repeated checkups on his body, or exhibit maladaptive avoidance, avoids doctor appointments and hospitals. Illness preoccupation has been present for at least 6 months, but the specific illness that's feared may change over the period of time. The illness-related preoccupation is not better explained by other mental disorders. Specify whether care-seeking type or care avoidant type. Factitious disorder, also known as Munchausen disease or Munchausen disorder. Factitious disorder or Munchausen syndrome derives from the Baron Munchausen, okay, which is basically a character loosely based on a German nobleman. His name is Karl Friedrich von Munchausen. The historical Baron became a well-known storyteller in the late 18th century for entertaining dinner guests with tales about his adventures during the Russian-Turkish War. The German-born writer, basically anonymously published a book in which he heavily fictionalized the version of Baron Munchausen, telling many fantastic and impossible stories about himself. In our language in Egypt, we call him Abu Lama. I mean, if anybody knows this terminology. Anyway, uh, there's a doctor, his name is Richard Asher. Used his name in certain, he was a British, endocrinologist and hematologist. And he discovered this condition where the patient is uh, fabricating, disease on himself or on others. And he called it Munchausen disorder, Richard Asher. And he published an article in the Lancet in 1951. I mean, I wanted to just give you a background so you understand the names, where it's coming from. This is Richard Asher. And I showed you the picture of the Baron Munchausen. So, what is factitious disorder? Factitious disorder is a falsification of physical or psychological signs and symptoms, or induction of injury or disease associated with identified deception. The individual presents himself or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. So this is different than malingering. Malingering, there is a reward from acting like this, okay? But here, there's no reward. The patient is just making up that he's sick. I had a patient like this. I remember that first came to me with a little bit of low back pain. I injected his back. Returned back next week, doing well with the lower back. Neck is hurting now. I started to inject his neck. Then he came, his knees are hurting. This, that. I mean, it's like after a few times, I said to myself, I mean, stop, okay, stop here. And this is we're not going anywhere. Every time you fix something, there's something else that shows up. So anyway, uh, so this is really factitious disorder. This is a true a factitious disorder. The behavior is not better explained by another mental disorder, such as delusional or another psychotic disorder. Specify whether it's a single episode or recurrent episode. I mean, this guy that the patient I told you about, literally have seen every doctor in the hospital from all disciplines, kidney doctors, hematologists, you name it, GI. I mean, he becomes satisfied when he, you know, um, introduce himself to others as a sick person. Without any rewards. There's no money in it. He's not gonna get off his job, getting a vacation or this or that. I mean, there's nothing. Okay. Factitious disorder imposed on another, and this is, I've seen this also, uh, previously called factitious disorder by proxy. Okay, so take a note of the different terminologies. Factitious disorder imposed on another. This is the DSM-5. In old days, it's used to be called previously fictitious by a disorder by proxy. Falsification of physical or psychological signs or symptoms, or induction of injury or disease in another associated with identified deception. The individual presents another individual victim to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external reward. The patient that I had basically was a veteran that had a serious injury, and he was basically bedbound, and literally he used to live in the VA hospital between, the intensive care and, the irregular room, and he was mechanically ventilated. Every time we try to send him home, his wife will go inside his room and do something that will flip things on us. Like she will disconnect the ventilator. She doesn't mean to kill him or do anything. She just wants to alert us that he's ill and he cannot go home. Okay. Uh, and until we were able to pick her up on the cameras, doing some crazy stuff, while she's on his bedside. So this is factitious disorder imposed on us. Adjustment disorders, another cause of pain. Remember, we said we have three causes of psychological pain. This is one of them. Adjustment disorders, the development of emotional or behavioral symptoms in response to an identifiable stressor, occurring within 3 months of the onset of the stressor. These symptoms behaviors are clinically significant, as evidenced by one or both of the following: marked distress that's out of proportion to the severity or intensity of the stressor, taking into account the external context and the cultural factors that might influence symptom severity and presentation. Significant impairment in social, occupational, and other important areas of function. The stress-related disturbance doesn't meet the criteria for another mental disorder. I had a patient, basically, that, in Saudi Arabia, in fact, a lady that came to me, uh, she was coming from one of the other nearby countries that had war going on. So these guys were, basically extremely stressed. And her husband was working in Saudi Arabia. So she had some type of, pain disorder that initially I thought it's somatic, physical, very simple. She localized a certain area in her body, but with multiple visits, I started to realize that she's giving me different areas every time. So, taking history from her, good history, trying to understand what's going on, I started to realize that we're talking about a psychological disorder more than it's a real somatic disorder. So sometimes, you need to meet with the patient more than once to have a good idea of what's going on with the patient. And I did some injection, and it did help for short term, but patient came back with other symptoms. This patient literally was having what we call adjustment disorder. But the good news is usually these symptoms do not persist more than 6 months. Once the stressor or its consequences have terminated, the symptoms does not persist for more than additional 6 months. So this is the good news about adjustment disorders. Specify whether there's a depressed mood, anxiety, depressed mood with disturbance of conduct, with mixed disturbance of emotions and conduct. This patient was clearly was that I was talking about was clearly depressed and anxious. Okay, malingering. Um, I want to mention what we call Waddell signs. These signs are classics in orthopedics here, developed by Dr. Waddell in the 80s. And these are non-organic physical signs, non-anatomical superficial tenderness, non-anatomical weakness or sensory loss, simulation tests with axial loading and rotation uh, uh, producing pain, distraction test or flip test, in which patient has no pain with full extension of the knee while seated, but the supine straight leg raising is markedly positive, overreaction verbally or exaggerated body language. Waddell et al. Spine, 1980. Gordon Waddell. The Waddell signs are there isn't really much evidence behind it, but it became like a classic of you know patients that are malingering. So everyone is using the Waddell signs, despite we lacking some evidence behind. So or scientific evidence behind. So please take a note of these Waddell signs. You're gonna need them one of these days. And as I said, it became a universal and classic science for malingering. Malingering in DSM-5 has a V code. So what is V code? V code is not a psychological or mental disorder. So when I say malingering, this is not a mental disorder because malingering usually has a secondary reward. Okay? For example, avoiding military duty, avoiding work, obtaining financial compensation, and obtaining drugs, for example, opioids. We'll jump into another condition called body dysmorphic disorder. By the way, malingering is common. I've seen it a lot. And I remember back in the United States, we used to, even send people, hire people to see these patients at home. I remember a patient that came to me basically paralyzed on a wheelchair. Okay, and basically he cannot move any part of his body except the tips of his fingers. So when he came to me, I asked him, "What do you want?" Basically, he said, "I need an electric wheelchair." I said, "Well, makes sense." So I put a consultation to the rehab department. These are the guys who were, giving electric wheelchair. So I got a call next day, and the head of the department, she told me, that this guy basically is the boyfriend of one of her, secretaries in the department. And the secretary knows him very well. This guy walks and everything. I mean, he doesn't have nothing. So what is the problem? He wants electrical wheelchair, okay, because he wants to sell it because it costs like maybe $35,000. So he wanted the VA to give it to him. So of course, it ended by like he got nothing. But I just want to tell you, I mean, if I didn't know, I mean, this guy might be able to get the electric wheelchair. I mean, just one story about malingering. So we see it a lot. Body dysmorphic disorder. This one I don't see it a lot, but um, basically it's a mental health condition in which you cannot stop thinking about one or more perceived defects or flaws in your appearance. A flaw that appears minor or can be seen by others, but you may feel so embarrassed, ashamed, and anxious that you may avoid many social situations. I had a case like this. This is not a common problem, but I had a case like this where the patient came to me. He's asking for, regenerative injection therapies. He was an athlete, and he claims that his muscles are getting deconditioned. He's not able to do things like he used to be. And his ligaments, all his joints are hurting, ligaments, tendons. And so I started to do some injections in certain areas. And then I kind of found that this guy is looking for other, parts of his body, literally wants me to inject his whole body. And the reason behind it that he doesn't look like he's, like he used to be. Uh, I mean, for me, if anyone sees this guy, they'll say this guy is an athlete. A bodybuilder. But for himself, he's looking down to him. He's not the way he was, this and that. So I started to, look it up, and I found that this guy has this what we call body dysmorphic syndrome. And by the way, body dysmorphic syndrome nowadays in the DSM-5 is not under the somatoform disorders anymore. It's under the obsessive compulsive disorder. So they changed its location. It still carries the same name, but they changed the location from being under somatoform disorders to obsessive compulsive disorders. Okay, summary for the whole things that I give in the last few slides here. Number one, disproportionate physical symptoms. This is somatic symptom disorder. Preoccupation, having a serious illness. This is hypochondriasis, or we call it nowadays illness anxiety disorder. Seeking psychological pain is basically functional neurological disorder or conversion disorder. So remember, conversion disorder, I told you that these patients, they're looking for a psychological gain, not something physical. Okay? Sometimes you have to, investigate what's going on with the patient's social history, psychological history, to find out the psychological gain from, claiming that he's paralyzed or blind or whatever. Seeking the sweet role is factitious disorder. Okay, so this is something different. Seeking a secondary gain, physical gain, is malingering. And this is not a mental disorder. A close temporal association between the psychological factors and the development of the medical condition. This is basically psychological factors that affect other medical conditions. Development of emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the onset of the stressor. This is adjustment disorder. Patient cannot stop thinking about one or more perceived defects or flaws in his appearance. This is body dysmorphic disorder. So this is a nice summary to the previous slides that I gave. Okay, we're gonna change topics. We'll talk about a serious problem, which is opioid use disorders. Opioid use disorders is widespread and underdiagnosed. In the United States alone, 92 millions are opioid users. 15 millions are high opioid utilizers. and 2 million are opioid addicts. I mean, we're talking about a serious problem in the community. By definition, opioid use disorders, OUD, is a problematic pattern of opioid use leading to clinically significant impairment or distress, as manifested by at least two of the following occurring within a 12-month period. Opioids are often taken in larger amounts or over a longer period than was intended. There is a persistent desire or unsuccessful efforts to cut down or control opioid use. Okay, compare this to alcohol use disorders. Okay, a great deal of time is spent in activities necessary to obtain the opioid use, the opioid, to obtain the opioid, use the opioid, or recover from its effects. Craving or strong desire or urge to use opioids. Recurrent opioid use resulting in failure to fulfill major role obligations at work, school, or at home. Continued opioid use despite having persistent, recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Important social, occupational, or recreational activities are given up or reduced because of opioid use. I mean, if you think about all what I've just said, this is very similar to alcohol use disorder. I mean, they're basically utilizing similar terminologies here. Um, other to continue, the DSM-5 criteria for opioid use disorders. Recurrent opioid use in situations in which it's physically hazardous. Continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by a substance. Tolerance, as defined by a need for markedly increased amounts of opioids to achieve intoxication or desired effect, a markedly diminished effect with continued use of the same amount of opioid. Withdrawal symptoms as manifested by either of the following characteristic of opioid withdrawal syndrome, opioids or a closely related substance are taken to relieve or avoid withdrawal symptoms. Specify if patients on maintenance therapy or in a controlled environment. The commonest two drugs for maintenance therapy are basically methadone and buprenorphine. Mnemonics, same like alcohol use disorder. Cage, have you ever felt that you should cut down on your drinking? Have you ever become annoyed by criticism or drinking of your drinking? Have you ever felt guilty about your drinking? Have you ever had a morning eye opener to get rid of hangover? Same like you know alcohol disorders. It's called the cage. This is a classic mnemonic. Okay, you should know it. I mean, ABC medicine here. Also, we have a tool. To continue the opioid use disorders, I would like to introduce a very nice tool called the opioid risk tool that we used to utilize to kind of pick up those patients that could be risk of addiction. And basically, this opioid risk tool is composed of 5 questions: family history of substance abuse, personal history of substance abuse, age, history of pre-adolescent sexual abuse, psychological disease, such as attention deficit disorder, obsessive compulsive disorder, bipolar, schizophrenia. And then here it will give you the risk. Low risk is 0 to 3, moderate risk 4 to 7, and high risk is above 8. Okay, so to continue the next part of the lecture here, I want you to understand that pain is a complex phenomenon. It's basically related to sleep, related to your energy. Most patients, they have sleep disorders. Patients with chronic pain have sleep disorders and having fatigue. Also, they have anxiety and depression. It's like a vicious cycle here between sleep, energy, activity, and mood. Okay, we'll talk about major depression. Major depression, you can screen it by a very simple question here. All right, straightforward question, which is basically, are you feeling down, depressed, or hopeless most of the time over the last 2 weeks or not? These are the criteria for major depression. 5 of the following symptoms have been present during the same 2-week period and represent a change from previous function. At least one of the symptoms is either depressed mood or loss of interest or pleasure. According to DSM-5, you should have depressed mood most of the day, markedly diminished interest or pleasure, significant weight loss when not dieting or weight gain, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, diminished ability to think or concentrate, recurrent thoughts of death. Symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Episode is not attributable to physiological effects of a substance or another medical condition. The mnemonics are classic, really. CG caps, sleep disturbance, interest decreased, guilt feelings, energy decreased, concentration decreased, appetite up or down, psychomotor function reduced, and suicidal ideations. Try to remember this mnemonic. It's really very helpful for you in your daily practice. Generalized anxiety disorders, excessive anxiety and worry. All of these, like general whether depression or generalized anxiety disorders, are highly prevalent in chronic pain patients. Excessive anxiety and worry, individual finds it difficult to control the worry. Anxiety and worry are associated with 3 or more of the following 6 symptoms, which at least some symptoms have been present for more days than not in the last 6 months. For example, restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbance, difficulty falling or staying asleep, or restlessness, unsatisfying sleep. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The disturbance is not attributable to the physiological effects of a substance or another medical condition, such as hyperthyroidism. Disturbance is not better explained by other mental disorders. Mnemonics of anxiety disorders are watchers: worry, anxiety, tension in the muscles, concentration difficulty, hyperarousal or irritability, energy loss, restlessness, sleep disturbance. I use these mnemonics, to be honest with you. I mean, uh, the DSM-5 classification, I mean, you need some time to really memorize them. But these mnemonics, you can just, use them on your daily practice. Fibromyalgia, the mysterious medical condition defined by the presence of chronic, widespread pain, fatigue, waking unrefreshed, and cognitive symptoms. The cause of fibromyalgia is unknown. By definition, fibromyalgia is idiopathic, okay, or primary. All right. You will hear the terminology secondary fibromyalgia. I'm not sure this is really scientific or not, but the word fibromyalgia is primary. Okay, guys, it's exactly like when you say trigeminal neuralgia. Trigeminal neuralgia is primary condition. Okay, and other conditions, like chronic fatigue syndrome. The cause of fibromyalgia is unknown, but is believed to involve a combination of genetic and environmental factors. Environmental factors may include psychological stress, trauma, and certain infections. The pain appears to result from process in the central nervous system, a condition referred to central sensitization syndrome. Nowadays, we have some evidence that fibromyalgia could be related to small fiber neuropathy. An alternative hypothesis views fibromyalgia as a stress-related dysautonomia with neuropathic pain features. Dorsal root ganglia may be the key autonomic nociceptive short circuit sites. Fibromyalgia is estimated to affect 2 to 4% of the population. It's a very common condition. Women are affected about twice as often as men. Central sensitization, okay, and this picture shows the mediators that's involved, and it can basically, the central sensitization is either triggered by central activity or peripheral generators. There is an overlap of fibromyalgia with other systemic disorders. Like, for example, somatoform disorders. We just mentioned it in the beginning of the presentation, which also affect 4% of the population. A lot of times these guys are the overlap with fibromyalgia. Chronic fatigue syndrome, which affects 1% of the population. Multiple chemical sensitivities and exposure syndrome, like people that came from the Gulf War. For unknown reasons, they started to have these fibromyalgia symptoms. Again, as you see, fibromyalgia, overlaps with a lot of systemic syndromes. Exposure syndromes, multiple chemical sensitivity, psychological disorders, somatoform disorders, irritable bowel syndrome, chronic fatigue syndrome, restless leg syndrome, sleep apnea, Hashimoto's thyroiditis, Sjogren syndrome, well known to cause dry mouth, dry eyes, and genital mucosa. Irritable bladder syndrome. So irritable bowel syndrome and irritable bladder syndrome. Pelvic pain and TMJ pain. Chronic fatigue syndrome, which is basically a common problem. We see it when 1% of the population presents with fatigue, severe headaches, loss of memory, sleeping problems, muscle pain, and sore throat. Restless leg syndrome. Patients suffer from pulling, feeling like an electrical current, itching, aching, throbbing, sensation like bugs in the lower extremities, especially when they get near to sleep at night. IBS and its manifestations: constipation / diarrhea, abdominal cramps, bloating, mucus in the stool, passing of gas, food triggers. Okay, this is another condition that you see in fibromyalgia patients. TMJ disorders. You see this patients with fibromyalgia having problems with their TMJ. It clicks, it hurts, all of that stuff, especially with using their mandible here, like when they chew something or whatever. They hear it pop, very common. Fibromyalgia linked to obstructive sleep apnea. I'll be honest with you, I cannot, find the link between obstructive sleep apnea and fibromyalgia, but this is in the literature. Patients with fibromyalgia are linked to obstructive sleep apnea. Irritable bladder syndrome. Again, we talked about irritable bowel syndrome. Also, we have overreactive bladder, where the detursal muscle is contracting before the bladder is full. For ladies, they have pelvic pain, very commonly associated with fibromyalgia. Sjogren syndrome, dry eyes, damage to the eye surface, and dry mouth. Hashimoto's thyroiditis. This is a very common association with fibromyalgia. Ladies with Hashimoto's thyroiditis, one of the commonest thyroid diseases, is linked to fibromyalgia. And I see it all the time. They will present with a generalized body aches. American College of Rheumatology proposed diagnostic criteria for fibromyalgia in 2010. Fibromyalgia can be diagnosed if patient experiences widespread pain and associated symptoms, and these include unrefreshed sleep, cognitive symptoms, fatigue, other somatic symptoms. Symptoms have been present at the same level for 3 months. No other condition otherwise explains the pain. Again, I have to stress on this. According to the American College of Rheumatology, fibromyalgia is a primary condition, guys. Okay? American College of Rheumatology, 2010. A patient satisfies diagnostic criteria for fibromyalgia if the following 3 conditions are met. Widespread pain index, WPI above 7, and symptom severity scale score above 5, or WPI 3 to 6 and symptom scale above 9. Symptoms have been present at a similar level for at least 3 months. The patient doesn't have a disorder that would otherwise explain the pain. and this is basically the widespread pain index. It goes from 0 to 19, okay? And the symptom severity goes from 0 to 12. So you should get a chart like this, and you fill it up, and then we can calculate your symptoms here, severity. So here, 0 to 12, the upper section is 7 points, for example, and lower one is 2 points beside the widespread pain index. And then here, uh, for example, the widespread is 6 points. So this is how you calculate, for fibromyalgia with the new American College of Rheumatology criteria. I find it a little bit, complicated, to be honest with you. I just use, I look at the patient and see whether he's having a widespread pain all over his body. Ask him about fatigue, depression, headaches, sleep disorder, and I come out with the diagnosis. But if you want to be super accurate, use this criteria. In old days, we had a different criteria. The 1990. With 1990 criteria, you should have more than 11 out of 18 tender points. Okay, and this was actually much easier than the current criteria. Palliative care. Mental health issues in palliative care patients may be reversed, controlled, and understood. Bereavement. So I'll give you a quick review about grief, mourning, and bereavement. Grief is our personal experience of loss. Mourning is a public expression of our grief. Bereavement is the period after a loss during which the mourning occurs and grief is experienced. So bereavement is basically you add grief and mourning, you will have a bereavement. Bereavement is a period, is a time frame after a loss during which the mourning occurs and the grief is experienced. I think this is the easiest explanation for these three terms here. A quote from Elizabeth Kubler-Ross, a famous psychologist. The most beautiful people we have known are those who have known defeat, known suffering, known struggling, known loss, and have found their way out of the depths. These persons have an appreciation, a sensitivity, and an understanding of life that fills them with compassion, gentleness, and deep loving concern. Beautiful people do not just happen. 5 stages of grief, according to Elizabeth Kubler-Ross: denial, anger, bargaining, depression, and acceptance. These are classics now, guys. Okay, although nowadays they say that these do not have to come in this, order. I mean, so you can have bargaining before anger, depression, before bargaining, and so forth. It doesn't have to come in this order that was put by Elizabeth Kopp. But I mean, just remember these because these became, classics of medicine here. Denial, anger, DABDA. Denial, anger, bargaining, depression, and acceptance. Persistent complex bereavement disorder is basically individual experience the death of someone with whom he or she had a close relationship. Since the death, at least one of the following symptoms is experienced on more days than not, and to clinically significant degree, and has persisted for at least 12 months after the death in the case of bereaved adults and 6 months for bereaved children. Okay? This terminology, persistent complex bereavement disorder, is the DSM-5, definition. Now, what I understand that, I mean, they're planning to change this terminology soon. Okay, I don't know when, but this is what we have right now: persistent complex bereavement disorder. So, what are the symptoms? Persistent yearning and longing for the deceased, intense sorrow and emotional pain in response to the death, preoccupation with the deceased, preoccupation with the circumstances of death. Since the death, at least 6 of the following symptoms are experienced more days than not, and to clinically significant degree. Reactive death to death, marked difficulty accepting death, experiencing disbelief, difficulty with positive reminiscing about the disease, bitterness or anger related to the loss, maladaptive appraisals about oneself in relation to the deceased or the dead, excessive avoidance of reminders of the loss. Example, avoidance of individuals, places, or situations associated with the deceased. In children, this might include avoidance of thoughts and feelings regarding the deceased. Risk factors for a persistent complex bereavement disorder: who the person was, loss of a child, nature of the attachment, mood of loss or death, unexpected, violent, criminal, multiple losses, history of mental illness or poor coping, personality variables, lack of social support, losses resulting in major changes, multiple prior losses, elderly male widower, caring for the deceased for a long time. The differential diagnosis of persistent complex bereavement disorder is basically normal grief, depressive disorders, post-traumatic stress disorders, separation anxiety disorders. So with normal grief, it's less than 12 months in the case of an adult and less than 6 months in the case of children. With depressive disorders, they share together the sadness, the crying, and all of that stuff. But with major depressive disorders, compared to major depressive disorders, persistent complex bereavement disorder is characterized by a focus on the loss of this person. Post-traumatic disorders are individuals who experience bereavement as a result of traumatic death, may develop both post-traumatic disorder and persistent complex bereavement disorders. Both conditions can involve intrusive thoughts and avoidance, whereas the intrusions in PTSD revolve around the traumatic event. Intrusive memories in persistent complex bereavement disorder focus on the thoughts about many aspects of the relationship with the deceased. So with PTSD, the focus is basically the traumatic event, while with persistent complex Bereavement disorder, the focus is multiple, and basically uh, looking into the many aspects of the relationship with the deceased. Lastly, is separation anxiety disorder, which is characterized by anxiety about so the last one, as far as the differential diagnosis of persistent complex bereavement disorder, is separation anxiety disorder. Whereas in separation anxiety disorder is characterized by anxiety about the separation from current attachment figures. Whereas persistent complex bereavement disorder involves distress about separation from deceased individual. Grief versus depression. Grief, irritability, depression, guilt, grief, deep sadness, depression, preoccupation with worthlessness. Grief is difficulty practicing acceptance, while depression is prolonged difficulties functioning. Suicidal ideation, seeing or hearing things related to the loss. Similarities, intense malaise, sleeping disruption, loss of appetite, and weight loss. Existential distress. Existential distress or suffering at end of life has been defined as hopelessness, futility, burden to others, loss of sense of dignity, profound loneliness, intolerable emptiness, remorse, sadness, loss of meaning, desire for death, or loss of will to live, and threats to self identity. It is not relieved by treatment of physical symptoms and can occur in the absence of such symptoms. Key learning points. According to Dr. Cicely Saunders, she coined the term total pain and suggested that the pain can be understood as having physical, psychological, social, emotional, and spiritual components. The combination of these elements are believed to result in total pain experience that's individualized and specific to each patient's particular situation. Psychogenic pain is backed up by the DSM-5, is divided into three categories: somatic pain disorder, somatic symptom disorder, adjustment disorder, and psychological factors affecting other medical conditions. Identifying opioid use disorders, anxiety, and depression in the context of chronic pain is of paramount importance. Fibromyalgia, pathophysiology is still a myth. Is it a rheumatic, neurologic, or mental health disease? Thank you. My reference in this presentation is the DSM-5, Diagnostic and Statistical Manual of Mental Disorders, 5th edition. Thank you.